conclude the session or probably the meeting with this talk. So let me begin by asking this simple question as to what constitutes a large ASD. Unfortunately, there is no universal definition, but most of the groups will agree that in adults, a transesophageal echo diameter of more than 25 millimeters will be considered as large. And in children, if you have a TE or a TTE diameter in millimeters, more than 150% of the body weight in kilograms, you will consider that as a large ASD in a child. For example, if you have a 10 kg child, ASD measuring more than 15 millimeters would be considered as large. Now, unfortunately, large ASDs don't come as a single entity. They are accompanied by rim abnormalities in the form of inadequate rim length, inadequate rim strength, and many times malalignment of the septum primum and septum secundum. Technical failure is not an uncommon thing when you use a routine technique of closing these large ASDs along with rim abnormalities. This combination, as a matter of fact, is a perfect recipe for a technical failure. Now, some of you may ask me as to what is a routine technique of ASD closure, and the routine technique of ASD closure is opening the left atrial disc just outside the left superior pulmonary vein, and then getting the opened up disc against the interatrial septum, and then releasing the waist and the right atrial disc to close the defect. So before I go into the various techniques, I think let's talk about let's see some of the cases of large ASDs. So this is what I would consider as really large, a 39 or a 40 millimeter measurement here. This is yet another large ASD in an adult measuring something like 38 or 39 millimeters. And these are the two large ASDs in children. This is around 7 kg, measuring somewhere 18 to 19 millimeters. And here again, you will see that this is a child who is around 6 to 7 kgs again, and measuring 19 millimeters on transesophageal echo. So these are some of the associated rim abnormalities. This is absent of aortic rim, really not a great concern for technical success. This is a deficient superior vena cava rim. This is a large ASD with a posterior rim deficiency, and this is a large ASD with a IVC rim deficiency. So these are some of the cases where technical failure is almost guaranteed if you don't have enough experience and expertise to get the device in place. It's not only the length of the rim, but sometimes even the strength of the rim, which unfortunately cannot be judged with any currently available modality, and it is mainly a subjective way of looking at it. So this is a septum primum, which is aneurysmal, and if you see the amount it moves, that sometimes capturing the septum primum out here may not be very easy, and the device will fall across the defect into the right atrium. Now, this is the malalignment that I have been talking about, malalignment between septum primum and septum secundum, as you can see here. And in a bicaval view, you will be able to appreciate the alignment of the septum primum, which is attached to the roof of the left atrium, and you look at the septum secundum. So see the amount of malalignment between the primum and the septum secundum. Now, if you ask me what are the basic mechanisms why we fail, so the two basic mechanisms, one is the inability to align the left atrial disc with the plane of the interatrial septum. And in children with large ASDs, it is predominantly inability to accommodate the opened left atrial disc, which then secondarily results into malalignment, and the device tends to fall across the defect into the right atrium. So this is what I mean by primary malalignment. This is what happens. So instead of the left atrial disc opening parallel to the interatrial septum, it keeps on opening perpendicular to the interatrial septum, and that's quite frustrating to see that. So in order to overcome the problem of malalignment, you can change the delivery of change the mode of delivery of the device, or change the delivery sheath, or use an additional support. And I will show you some of the examples. So instead of coming out of the left superior pulmonary vein, you can come out of the right superior pulmonary vein and align yourself with the plane of the interatrial septum. And if you're lucky, you may just be able to overcome this. Or you can use one of these delivery sheaths, either a Hausdorff sheath, which is not very easily available. Fustar is definitely available from Lifetech, or what we call as a side cutting sheath. The only problem of this sheath is that if the device doesn't sit properly and if you have to slenderize the device again, these cut edges might fold themselves inside, and then taking the device in may be really difficult. And as you know that we have been very fond of using this additional support, and we described this technique in 2004. And I'm very happy to tell you that 20 years down the line, this technique is still one of the commonest techniques used the world over for taking care of large ASDs in adults or even in children. So this is one of those cases where there was a huge ASD measuring around 38 or 39 millimeters, and you can see that the surrounding rims are quite deficient, and even on 3D, just a sliver of tissue all around the defect. So we used the balloon-assisted technique, as has been shown here, where we keep the balloon across the defect, open up the LA disc, then the waist and the RA disc, and once you are happy, then you deflate the balloon, and you can see that the disc forms the device forms itself so very well, and then you can release the device. And this was a 44 millimeter fenestrated device. And you can see that there is a flow across the fenestration whereby you can decompress the left atrium and prevent acute pulmonary edema. This balloon-assisted technique can also be used in children. This is a 6 kg child, has a 17 millimeter atrial septal defect, and we went on to use a 18 millimeter device, so almost 300% the weight of the child in kgs. And you can see that this is the left atrial disc here, and then the waist and the right atrial disc opened up. The device looks pretty ugly, but as the balloon starts deflating, the device forms beautifully, and you can see that the ASD was closed pretty successfully. So this is an example of inability to accommodate. Now you can see that there is just no place in the left atrium for this 19 or a 20 millimeter device. When it opens up, there is no place. So it kind of drops across the defect into the right atrium. So the malalignment is secondary to inability to accommodate the left atrial disc within the small LA cavity. In order to address this particular problem of accommodation, in 2013, we described a group of techniques called as left atrial disc engagement, disengagement techniques. What do they mean? The principle underlying these group of techniques remains the same. You engage the left atrial disc, release the waist, followed by the release of the RA disc, results into spontaneous disengagement of the left atrial disc, and the device kind of captures all the rims very, very beautifully. So this is the engagement, release of the waist, release of the RA disc, and there is a spontaneous disengagement of the LA disc, and you can see that the device is beautifully sitting here. This particular technique is also called as the LSPV technique because that is the commonest site of engagement, but there is nothing sacrosanct about the left superior pulmonary vein, and you can engage the left atrial disc into the right superior pulmonary vein. Sometimes it gets accidentally engaged into the LA appendage or LA roof, and I'm going to show you some such examples. So this is the classical LSPV technique where we have engaged into the left superior pulmonary vein, the waist is released, followed by the release of the RA disc, and see how beautifully the device is sitting into the across the interatrial septum. This is the engagement into the right superior pulmonary vein here, and you can see that when there is no spontaneous disengagement, you are able to disengage it by forcing the left atrial disc out of the right superior pulmonary vein. So this is an example where while engaging it to the left superior pulmonary vein, it kind of automatically got disengaged and got engaged into the left atrial appendage. And again, this engagement was made use of to deliver the device. And this is an example where trying to engage into the right superior pulmonary vein got prematurely disengaged. Here it gets engaged into some part of the left atrial roof, which was used to deliver the device successfully. Now, this is a very important question. When there is no spontaneous disengagement, do you pull on the loading cable or you push on it. And this is our answer to this. I'm not sure whether it's the right answer, but the logic behind it I'll try and explain to you. So this is what happens, that there is too much of engagement inside the left superior pulmonary vein, so it refuses to disengage. Now what is the normal response is to pull on the cable. And if you try and pull on the cable, you see the right atrial disc has lost its alignment with the interatrial septum. Apart from injuring the left superior pulmonary vein, there is a chance that both the discs will come out of the defect, as it happened in this case, and dropped into the right atrium. So we have used a contrarian technique of pushing onto the cable. But you see how we push on the cable. We leave the redundancy on the cable, so it's not pushed in this direction, but pushed up, leaving a redundancy on the cable. Similarly, when there was no disengagement from the right superior pulmonary vein, we exactly did the same thing of pushing onto the cable with a redundancy on the cable, allowing it to disengage. So this is the principle of disengagement. A part of the vector tends to act in this particular direction, thereby pulling onto the engaged disc and disengaging it. I'm not sure whether that is the correct way. The only problem with this kind of a technique is, one is the injury to the pulmonary vein, so you have to be very careful. And secondly, when you push onto the cable, you knock onto the AV node, so the chances of heart block are pretty high. As I said, with this left atrial engagement disengagement, of course there is a failure of the procedure, and sometimes even with pull-push, you may not be able to succeed. Knock on the AV node and injury to the pulmonary vein, which can acutely result into bleeding and chronically into pulmonary venous stenosis. Both these complications, fortunately, we have not seen so far. So in conclusion, I think when it comes to large ASDs, whether in adults or in children, routine technique of deployment has limitations. Multiple techniques are available. Technical success with adequate experience and a little bit of expertise is close to 100%. However, technical success may not translate itself into clinical success because the problems of embolization, arrhythmias, most importantly heart blocks, thrombus formation, and erosion continue to bother the interventional community. So I'll leave you with this question, now that we can, whether we should. Thanks for your patient hearing, ladies and gentlemen.
Well, thanks, Bharat. That was an excellent presentation. I'm sure the audience who are enamored, they will want to say, yeah, we should go close all ASDs. Now, I have one question of you, is that the new cable that's now available, okay, it's got that redundancy bit, right? It's very flexible at distally. To what advantage is that? Where you can, since you understand so much of the dynamics, that whether it is made a difference in terms of your delivery and doing it, or the good old stiff cable was fine?
See, that is called the Traversio cable, and the Abbott is really gung-ho on that cable, and many of my colleagues are also using that cable. I have not used it
because
even in one case.
we get now devices only with the new cable.
No, sorry. We get it with the old cable. I have been using the old cable all through without any problem. As a matter of fact, I feel we cannot do what we can do with the old cable when it comes to Traversio because it doesn't have a pushability. And many of these memory abnormalities, either induced or accidental, the so-called cobra formation, and the induced, like I showed you, LSPV, RSPV, all these things can be done only with a stiff cable. If you have a cable which is floppy at the distal end, it has lost its pushability, and none of these techniques can be used with the new cable.
No, but probably the device, whichever disc, you're talking about the LA disc, probably that aligns better, no, reflection.
I don't think with the flexible cable it makes any difference to the alignment. What the argument is that the flexible cable allows you to release the device without it undergoing a recoil.
Yeah, right. Yeah.
And the recoil is of great importance for PDAs, the preemie PDAs or even in infants. But recoil for ASD, in our experience, is really not a very big deal. And we have rarely, or I don't remember a single case where we have lost a device because of the recoil of the ASD cable.
Because they almost always now supply, because we use everything in New York, and the cables also. So the cables are all necessarily the flexible ones.
I think these cables are very helpful in patients with the post-MI VSR because
Yeah.
their anatomy is totally different. Sometimes they are taking serpentinous shapes, so they give some time to align the thing, and it is very easy to do the procedure with those cables.
It's possible, but for ASDs, I don't find them of great use.
Sir, after pulmonary venous deployment, how do we make sure that we have not ended up injuring the pulmonary veins?
I mean, no, the only way you will know is when you have the endotracheal tube which is filled with blood, or if there is a loss of saturation. But usually, you have to be very careful. Don't push the cable like this. Let there be a redundancy on the cable. So the cable should actually curl on itself, and when it curls on itself, a part of the vector will pull out the device from the left superior pulmonary vein. So that is how it disengages. And that's where you have to be extremely careful. And I won't advise this technique to somebody who has not done a couple of hundred ASDs before attempting these techniques.
About that, you can do it in RSPV also, you mentioned, but at least I thought I either heard or saw this one. Zaid Amin advises, he wrote the original thing, right, about the whatever that, what baseball shape or whatever they call it.
No, really.
So he says that don't do it in RSPV, although I've been doing it. But is there any objection to doing it in RSPV?
I don't think so. The thing is, this really the original paper, the so-called LSPV technique, came from the Sick Kids Toronto group. Lee Benson's group was the first group, and actually it happened accidentally. When I spoke to Lee, he said that it actually happened accidentally. And then they noticed that such a thing can happen, and this memory abnormality can be used for a good end, and that's how they started doing it in children where the left atrium was small for them to accommodate the left atrial disc.
So since this disengagement technique has sort of become so, everybody's become aware of it, and we are doing that because we have not found the need to go for a balloon assist. So now because you do larger ASDs, you are quite, meaning if you do large ASDs, it's still fine. The thing is that how often do you now use the balloon assist?
All the time.
You still use
All the time. Okay. We size all the ASDs with balloons, and all the time I use balloon assist.
that
Almost more than 90%.
That adds to the cost of the procedure, right?
I mean, we have the same cost irrespective. We really have a package which includes the balloon. I agree with you.
The same balloon?
Same balloon, I use the same balloon. I take two venous accesses, one access for sizing the balloon, the second. Our procedure time for ASD closure is less than 20 minutes, almost always.
Which balloons do you?
The same AGA balloon, the Abbott
The
elongated
long one,
balloon.
not the round one is not
We have
necessary.
stopped the round one for many, many years now. Many years. I'm not advising that now if you have a straight centrally located, you need not do it. But since we size every ASD, ultimately why do you size? Everything is an approximation. Whether you do a 2 millimeter addition, 4 millimeter addition, 6 millimeter, it's all an approximation. And even balloon sizing is an approximation. But in our experience, balloon sizing is the best of the approximations, because the number of ASD devices I had to change after I came back to balloon sizing is far too less as compared to what we would by just looking at the TE and deciding that we will add 2 millimeter, 4 millimeter, aortic rim is absent, so let's do 6 millimeter. That's an approximation as well.
Towards the success of the procedure as such, we've not felt the need. Maybe at least I maybe don't do as large ASDs as you do, but I have never felt the need in recent last 5 years or so to use a balloon assist technique, especially because of these new techniques of keeping it in the LSPV or RSPV, or coming from just the alignment change. It helps, you know.
See, my answer to you is people who are smart in operating don't need help of other techniques. But I think for somebody who is on the learning curve and wants to venture into a little complex anatomy, I think balloon assist is a technique, what I would call is a foolproof technique. Even if you are not
in terms of
very
the success
skillful.
of the procedure, in terms of a real large ASD, because you've done 40 walas also. So now, because you have used balloon assist, you will land up deploying it. But do you guarantee that that's not going to embolize later?
I don't think.
Probably it makes the ease of the procedure with a balloon assist makes you want to do large ones, but the large ones then do embolize, right? So
See-
is the embolization rate got to do anything with balloon assist?
No, I'll tell you very frankly that embolization has become less with increasing experience. But if you ask me whether it has become zero, the answer is clearly no. There are two reasons for that. One is that although we are able to see the length of the rim, we cannot judge the strength of the rim in every patient. It is our subjective feeling that probably this rim may be able to take it. And the second thing, which we have not been really looking at very carefully, is malalignment. I think of late, our embolizations have been more related to malalignment rather than to the size of the defect or the rim abnormalities. So when we look at this very carefully, in last 3 years, I think I would say that maybe we have embolized maybe 5 or 6 cases, out of which 4 or 5 have been related to malalignment. And most of the malalignments have been with septum primum and secundum beautifully seen on bicaval views.
Talking about embolization, it happens by and large with large devices. Is there, would you want to tell the audience a cutoff level as to where you will not attempt to retrieve the device and you'll simply send to surgery? My rule of the thumb is that anything more than 30 or 28, if it has embolized, don't even try to retrieve it. I believe in sending it to the surgeon. Because the kind of a hardware that you would need for retrieving anything more than 28 plus is huge in terms of groin access, the availability of those kind of sheets to do it, and availability of
So
retrieval device.
how we look at it, whether we want to retrieve or not. So we will look at the anatomy very carefully. If we feel that this was a technical error and not the choice of the patient in terms of the rim abnormalities, we would probably consider retrieving if the device is less than 40 millimeters, because we don't have a 42 or a 44 available on shelf all the time. So even retrieving a 40 millimeter will be useless, because then we don't have a device higher than that. But if it was a 28, 30, and I thought I have undersized this particular device and that I could close it with a 32 or a 34, the rims don't look all that bad, I will still try and retrieve if it is not entrapped under the tricuspid or the mitral valve. The most dangerous is underneath the mitral valve if it has embolized on the left side. And the second is if it is entrapped, it's not moving at all underneath the tricuspid valve. Because those are the patients where I feel that the chances of me traumatizing the patients are much higher. But if the device is 30 or 32, we have a 16 French sheath all the time from Cook. We have multiple snares available. And as I told you, for larger devices, 30, 32, we always use a 2 snares technique to not only grasp the device, but even to slenderize them.
Come from the jugular.
sheath.
You come from the jugular
Yes,
for that, yeah.
yes, not into the jugular. We pass both through the femoral, and we kind of play with 2 snares so as to align the screw with the axis of the sheath. Because otherwise it comes either oblique or perpendicular, in which case, even though you can grab the device, you will never be able to slenderize it. And what you want is a slenderized device. And if the device is in the aorta, I think getting it is a slam dunk. But if it is in the pulmonary artery or if it is underneath the AV valve, getting the devices is quite difficult. And I take your point, rather than traumatizing the patient, it's much safer to send the patient to the operating room.
As a general rule, because of this need for 16 French and armamentarium not available, and invariably it's the large ones that embolize. So I would, meaning as an advice, I would say that anything more than 28 millimeters, rather not retrieve, send it
I think I would leave it to your level of comfort and then take a call.
Sir, so one last question, sir. Sir, like for not so very experienced users like us, so what we normally do is we always go into the LSPV, and then if not, we try once or twice in the RSPV, if we can't align the device. Now, is there a correlation between like which rim is deficient, and specifically which vein should we cannulate?
I think it's a great question, really speaking. And as you very rightly said, that if you have a deficiency of the superior or the anterior rim, then maybe coming from the left superior pulmonary vein will be a better technique. As against that, if you have an inferior and posterior rim deficiencies, coming from the right superior pulmonary vein is a better technique. How we started coming from the LSPV in all the cases because that is how we were trained. And then when we failed from LSPV as a matter of, not as a matter of choice, but as a backup, we would come from the RSPV. But what we learned over a period of time is probably, this is how you look at it. The anterior and superior come from the left side, and if it is inferior and posterior, come from the right side.
So one question, sir, we have not discussed. So what is the status of sinus venosus ASD closure with device?
So now sinus venosus ASD, as you know, has been in vogue for last 10 years. And there are certain sinus venosus ASDs which can be closed with a transcatheter technique and certain sinus venosus which cannot be closed. Now, what are the rules of the thumb? So first is that if the vertical size of the sinus venosus ASD is more than the diameter of the SVC at the SVC-RA junction, most of these sinus venosus ASDs are too large, and even guys like Shiva, who has probably the largest experience in the world, will probably refrain from closing it. The second important thing is the anomalous pulmonary venous return. If the anomalous pulmonary veins are draining directly into the right atrium, I think it's not a great idea to address that in the cath lab and better be sent to the operating room. Now, if the pulmonary veins are draining very high up into the SVC, you can still do them in the cath lab because the argument of the interventionist is that if these veins cannot be diverted into the left atrium by the surgeons, why we should be diverting? We will also leave them into the right atrium. The best candidates are if you have a single pulmonary vein which is draining anomalously and which is draining posteriorly so that it is in continuum with the posterior left atrial wall. It can be easily exteriorized by using a covered stent. Now, the problem is that most of these patients require a very large covered stents. Initially, they used to start with 40, 50, but the chances of embolization were high. So nowadays, it is a common practice to use a 60 or a 70 millimeter covered stent. My basic, not, I wouldn't say objection, but why I don't think that I am trying to follow many of the interventionists in closing the sinus venosus ASDs is for two reasons. The first reason is to have a long stent hanging into the right atrial cavity with half of the stent not even in touch with the right atrial wall. My concern is that how do I know that 20 years down the line these stents will not be a nidus to forming thrombi, thromboembolism, and pulmonary hypertension. That concerns me, and many times I wake up in the middle of the night with this thought that a sinus venosus ASD is such a simple lesion, I might end up with a pulmonary hypertension. The second important reason why I feel that this may not be a great strategy in adults where it is commonly used is that many of these atria have undergone remodeling, both mechanical and electrical. And if these were to develop atrial fibrillation, that will make the things even worse for thrombus formation and for causing of pulmonary thromboembolism. So that is the reason why I am not so gung-ho over closing sinus venosus ASDs. Although I tell my patients that no, you should not do. I tell them that this is an alternative which is available. I don't practice it, but these are the guys who do it, and let the patients take their own call based on how they find this particular modality of closure. But that is where we stand as far as sinus venosus ASD is concerned.
Sir, I have few questions. Sir. Like we always learn from sir that 28 mm or 30 mm of ASDs is the cutoff. Is there a cutoff for?
No, I always used to tell this to the people that whenever people ask me about the size of the ASD, I am reminded of Archimedes. He always said that if you give me a place to stand outside the earth and if you give me a pole long enough, I can move the earth. So it's similar. If you give me a device which is large enough to take care of the ASD, I would probably close any ASD. provided the rims are adequate. The problem of closing large ASDs, in my opinion, is the rim. I doubt that it really compromises the safety.
So some many a times you find the aorta and the posterior. The aorta is deficient and the posterior is like 3 or 2 in a large ASD.
I would not do it. If you have no aortic rim and the posterior rim is doubtful, my policy in interventions has been, when in doubt, don't. So if I have any doubt about the stability, about complications, for whatever reasons, I would back out. Because there are very safe alternatives available. Surgery is very, very safe, has withstood the test of time for more than half a century. Why should we not allow our? That's why I said that I will leave you with this question now that we can, whether we should. And these are some of the cases where I would give a second thought before really venturing into closing them.
So what are the other scenarios where you would not do it?
So one of the things that I would be really these things is deficiency of the rims. The second one is if there is a very significant malalignment, that really scares me. Also, patients who have multiple ASDs with paradoxical embolism, history of paradoxical embolism, where I want to practically close each and every ASD. And of course, some of the cases of large ASDs in small children. Although we were very gung-ho, we have a lot of presentations on large ASDs in small children, and touch wood, we have not had many complications, but the concern about complete heart block, really, as I see more and more cases where we had to actually give up the procedure, bring them back the second time, and we were successful the second time. But I think the problems of complete heart block are real. And that is why my adrenaline levels for closing large ASDs in small children is probably not the same as it was maybe 10 or 12 years back. So these are some of the patients I would probably back out.
So last question, sir. If there is pulmonary hypertension, say a 50-year-old, a fenestrated device, like for me I have a P by T of 60, you do a CAT study, you find a borderline CAT study. A fenestrated device versus if at all you send to the surgeon and he does a fenestrated patch, is there a benefit? The natural history of the disease, does it change? Or is it just a symptomatic benefit?
See, now I'll tell you two things. Pulmonary hypertension many times has been used very loosely. Pulmonary hypertension in adults can be of two origins. Either it's pre-capillary or if it's post-capillary. Now, when you say it is a pulmonary vascular disease or the so-called Eisenmengers, those are the ones which are very difficult to select, more so in pre-tricuspid shunts. So we would look at multiple variables to decide the operability, not only the PVR, SVR, PVR by SVR, all that. We would look at the age of the patient, syndromic or non-syndromic, where the patient still has symptoms suggestive of increased pulmonary blood flow, the heart size, the flow murmurs across the tricuspid, across the pulmonary, baseline saturations, the flow through the pulmonary veins, everything, before we decide on the pretest probability of reversibility and non-reversibility. Then we take him to the cath lab and look at the PVR. So we will interpret PVR or PVR by SVR ratio in the background of the clinical picture. No matter who tells me what, that no, this is a sure shot, I would look at everything before I decide whether I want to close it. And as I said, when in doubt, a fenestrated device, and when in too much of doubt, for a pulmonary vascular disease, I will never close it.
What about role of pulmonary vasodilators for a period of time, bringing them back?
So we would not close it. We would put them on pulmonary vasodilators and bring them back after 6 months, 1 year, 1.5 years, 2 years. When I say we will not close it, it doesn't mean permanently we will not close it. We will not close it at that point in time. When it comes to post-capillary pulmonary hypertension, which you see in elderly, 60, 70, so usually what we do is that these are the patients, we will bring them to the table only after 2 to 3 weeks of aggressive diuresis, vasodilators, and sometimes even beta blockers. We will try and take care of all their comorbidities as well as we can, may it be atrial fibrillation, may it be CKD, may it be hypertension, everything, and then bring them on the table. And then we will try and do both balloon occlusion and device occlusion and decide whether we want to go ahead and do it or not. But most often what we have seen, after we have started preparing these patients, most of them do reasonably well, and we would close them with a fenestrated device, but a fenestration made in the factory. These are the patients where you can make fenestration in the lab and also do it, because you don't need a fenestration for a very long time. The heart will remodel itself within a few weeks, and thereafter, even if the fenestration is gone, you are not worried. But for pre-capillary pulmonary hypertension, if you are intending to close with a fenestrated device, my advice would be close it with a fenestrated device which is made in the factory, because that has to remain open for a very long time. You don't know how the pulmonary hypertension will behave. It may behave well for first 6 months, 1 year, 2 years, even up to 5 years, only to haunt you again after 5 years and come back with a vengeance. So this is how we look at pulmonary hypertension, whether pre-capillary, post-capillary, and that's our approach.
Are they still in search of an indication? PFO?
Deviation from this topic, but your opinion about PFO closure?
Occlusion, PFO occlusion. Of course, I think PFO occlusion is, I'm not a complete believer that it's a device in search of an indication. I think that my threshold for closing PFOs is rather high. I'm a Puritan when it comes to closing PFOs. So first and foremost is that I will look at whether here the PFO is an innocent bystander, or whether it is really something where it is associated with the so-called cryptogenic stroke or stroke. The second thing is that I would be pretty aggressive in evaluating other causes. So if you bring to me a 60-year-old gentleman with hypertension, diabetes, and maybe, having some lacunar infarcts, even if he has a PFO, my threshold in closing this PFO will be very, very high. On the other hand, if you bring him to me, even if the patient has no risk factors, no hypertension, no diabetes, non-smoker, a relatively younger patient, maybe 35 years old, but just complains of some tingling, numbness, something, some amaurosis fugax, but MRI is completely normal. Again, even if there is a PFO, my threshold for closing this PFO will be very, very high. If I have a young patient, no hypertension, no diabetes, no procoagulant state, no atrial fibrillation, has a PFO where the right to left shunt at rest without Valsalva, and if you tell me that this patient has had a stroke, aphasia, right hemiplegia, or something like that, made a brilliant recovery, MRI showing me a superficial single infarction, yes, I will go after that PFO like never before. I would definitely fix that PFO, because stroke can be very, very debilitating, especially in a younger individual. So I will be quite choosy in approaching.
So Rajiv, cause-effect wise, you prove first that there is a cause for that stroke. It's not cryptogenic, and that PFO is not an innocent bystander. I'm also for closing such. And those kind of PFOs, I don't think you get dime a dozen. You understand? Yeah.
So my question to Dr. Dalvi, in PO4, as I understand, and the bubble test, you do from the upper limb or the lower limb?
Usually, for the sake of comfort, I do it from the upper limb. But I know your point, because there can
Most
be...
of the clot arises from the lower limb.
I completely agree with you that... but most of the people who do the bubble test, they will do it from the upper limb. Very few people will do... I will tell you one thing. If you feel that after doing a Valsalva, there is a clear-cut aneurysm, and yet the bubbles are not going from the right to the left side, and if you have had a stroke with an MRI positive and no other causes, probably those are the patients where I would tell them that this could be false positive, and let me give it a shot from the lower limbs. But otherwise, for sake of convenience, it would be...
Sir, as a comment.
There is one tangential thought regarding the rim abnormalities, particularly in ASDs, where we are suspecting a malalignment of the rims in a larger ASDs. Can we design a device which is having slightly more softer design, larger size and softer design, so that the malaligned rims can be taken care and the chances of embolization will be less?
As a matter of fact, Ajay, if you know, there is a guy called Joseph Vetukuti. I don't know whether you have seen him. He's a very smart guy who was
come
in-
for Shafiq's meeting.
Yeah, he really was in US, Southampton for a very long time, then went to Michigan, and now he's back in India. He has manufactured or he has designed his own device, which is quite like Amplazar, but not Amplazar. And one of the designs which he has incorporated in this device is the thickness of the device, which is a much thicker device as compared to Amplazar. And that's why for a spiral septum or the so-called malaligned septum, it can really grab the rim on the left atrial side and the rim on the right atrial side. So that may be one of the devices which could take care of the ASDs with malaligned rims. Very true.